Well, there are a number of barriers to focal therapy becoming more accepted. I would say the most important one right now is the lack of robust clinical trials. As medical professionals, we want to see randomized, placebo-controlled clinical trials where we compare one technology, one form of therapy to a standard approach. And right now, we don't really have those. We don't have those in large numbers. Some of our larger series right now are 50 patients, which is very small. So we do need bona fide trials, but in order to have those, we need funding. And sometimes getting funding behind these trials is very difficult. It's very difficult to figure out what the comparative arm is. Do we compare it to active surveillance now? Because active surveillance will always have the best functional outcomes because those patients are not being treated, so their continence and potency should be unchanged. Or do we compare it to radical therapy? Focal therapy is a treatment that occupies a niche that's between active surveillance and radical whole gland therapy. So it's unique in that aspect, and it's very difficult to run a study that compares to both extremes, active surveillance for cancer that probably doesn't need to be treated, and then cancer that's treated radically that needs to be eradicated. We also have payment barriers. We have insurance barriers. So right now, the FDA in the United States has not approved focal therapy. Some of the devices that we use have 401k approval to ablate soft tissue, so we can utilize them for that purpose, but they don't have specific indications for focal therapy. And for that reason, some of the payers are not willing to pay for services. So for example, cryotherapy is a bona fide treatment that's accepted in the United States, but some of the other instruments that you can use for ablation, such as photodynamic therapy, irreversible electroporation, they don't really have billing codes right now. So unless you're doing this in a clinical trial setting where the patient's willing to pay cash, it's very difficult to do this. So that is a barrier, the payment model. Finally, we have patient-related barriers. Not all patients have heard about this, and on the other extreme, we have patients that have heard about it that think it's a great idea, but they don't qualify because medically their disease is not in that sweet spot for focal therapy. So there's a number of barriers, and focal therapy is still young. We've been thinking about this for going on 10 years right now. We have to look at patient selection criteria. We need more work on clinical trials, how to determine outcomes, how to salvage people that may not respond to focal therapy. How do we determine a number of things, which device is best for which particular cancer, based on location in the prostate. There's just a lot of work that needs to be done. But I think one of the key components is funding. If we have the funding behind it, then I think we can move this along at a much faster pace.